All right. Hello, and thank you for joining us for today's virtual education program at Cancer Support Committee South Bay. I'm Rebecca, the program manager, and I welcome you to this workshop titled A Psychiatrist's Guide to Cancer Treatment. Before we begin, if this is your first time joining us, CSC South Bay's mission is to uplift and strengthen people impacted by cancer by providing support, fostering compassionate communities, and breaking down barriers to care. Our vision is that everyone impacted by cancer receives the support they want and need throughout their experience. We serve the South Bay, Long Beach, and Orange County area all at no cost. Our program includes support groups, networking groups, healthy lifestyle classes, social activities, and educational programs like this workshop. Educational programs are open to all. If you'd like to hear more about our services or join our community, please visit our website at cscsouthbay.org. Before I introduce today's speaker, we ask you to keep your microphone muted to eliminate any distracting background noise. Please feel free to enter any general questions into the chat function found at the bottom of the Zoom window, and we can ask Dr. Palmer periodically. Without further ado, I'd like to introduce our workshop speaker. Dr. Richard Palmer is a board-certified psychiatrist and have been in practice in the South Bay for over 35 years. He is an assistant clinical professor at UCLA and supervised residents at Harbor-UCLA. He has also been a board member of our own professional advisory board at CSC South Bay for over 30 years. Thank you so much, Dr. Palmer, for being here with us today.
My pleasure, and greetings to all. This has become kind of a yearly event, and I look forward to it in terms of sharing my ideas and thoughts about how a psychiatrist and how psychiatric care can be helpful in treating the emotional problems that cancer patients experience. I thought I would start by kind of telling a little bit about my background and also just what a psychiatrist is. For those of you who don't know, a psychiatrist completes medical school and then has 4 years of training, which includes psychotherapy, learning medications, experiences in neurology, but very importantly, also interacting with medical patients. And I think it was during my rotation where I would do consultations on the medical floor that I became very aware of the interaction between emotions and pain, emotions and depression, and how improving the patient's emotional state often really improve the overall improvement in the patient's condition. Also, full disclosure, I have a very close family member who has been a cancer survivor. So I've been on both sides, both as a treating therapist and psychiatrist, but also as a caregiver. So I do have experiences in both, and I think both are really helpful in kind of making me the psychiatrist that has enabled me to effectively treat cancer patients. So I'd like to begin by stating that what I'm aware of is that when cancer is diagnosed, the focus tends to be on the treatment. It tends to be on finding an oncologist, ordering tests, MRIs, CAT scans, surgery, medications. There's a lot of focus on getting the medical aspects of the cancer dealt with, but there's often a neglect of the emotional aspects, and that's where I think not just psychiatrists but therapists and certainly groups like the cancer support community can be so helpful. When cancer is diagnosed, invariably people feel a sense of depression. I mean, it's very normal to have a grief reaction, and the various stages that one goes through in dealing with that I think are very common. So grief, depression, generally is something that resolves over time when the patients begin to receive treatment, when they receive support from family and caregivers and start the process. Generally over time, depression kind of resolves. However, there's a kind of depression that often results when patients experience severe feelings of depression, often triggered by emotional events like cancer, that don't resolve so easily. This is called clinical depression or major depressive illness. 10% of the population at any point will have experienced a major depression, a clinical depression. With cancer patients, it's 20 to 25%. And unfortunately, many of these do not receive the full treatment that could very, very effectively help them overcome their depression and get on with their lives. I'd like to talk a little bit about what I mean by severe depression and what the symptoms are. And a lot of these are also experienced by patients experiencing grief and resolve, but many of them don't. So a clinical depression is one that lasts, doesn't resolve, and begins to interfere with the patient's ability to effectively participate in their own treatment. It takes away from their ability to relate to their family and friends. They begin to be shut off from sources of help that are available that they are not able to access. So the symptoms of depression that I think are most important to be aware of, is a feeling of persistent sadness, anxiety, a lot of anxiety. Anxiety and depression go hand in hand, and feeling empty. Oftentimes people who are feeling this way feel apart from the world. They feel like they can't really interact. They can't really be part of their family. They cut off contact. They begin to withdraw. Loss of interest or pleasure in usual activities. The patient will give up hobbies, stop watching television programs that he's interested in, he or she is, stop making contact with friends and people, making excuses in terms of going out, staying in bed, but basically kind of losing interest and feeling that they're not part of life any longer. Anxiety. Again, I mentioned anxiety. Anxiety and depression go hand in hand. Anxiety can be um, expressed in different ways. Irritability, restlessness, excessive crying, anger toward people that are trying to help the individual. Oftentimes, it's very difficult for caregivers who are experiencing anger by the person that they're trying to help. Insomnia. Insomnia is a very, very, very common problem that we all invariably experience at one time or another. In depression, it's something that can be significantly uh, an impediment to their being able to kind of get on with life. And by depression, by sleeping problems, I mean difficulty falling asleep, difficulty staying asleep, um, waking up many times during the night, early morning awakening. And then there's also the kind of insomnia or the other kind of sleep problem where people sleep excessively, where they don't want to get up, they don't get out of bed, they have difficulty just mobilizing themselves. But insomnia is a very, very important and significant symptom of major depression. Decreased appetite and weight loss, major issue and a concern, particularly if the patient is on chemotherapy or on a medication that might possibly be causing a lack of appetite. So weight loss, something very, very much to be aware of in treating depression. Decreased energy and fatigue. Patient complains of feeling tired all the time. Everything is an effort. They have trouble getting mobilized to uh, get up and get dressed, to go to the doctor, to go outside and do normal activities. Very, very much a problem with depression, and one that is something that is sometimes overlooked because it's sort of fits in with people who are depressed or who have cancer and maybe not having the energy or not feel like doing things. But having depression and feeling tired and having no energy and fatigued is a major, major symptom of depression when it goes on for a while. Um, difficulty concentrating, making decisions, difficulty with memory. Oftentimes, this is overlooked. Oftentimes, people are thinking, "Oh my gosh, I must be developing a dementia." But very commonly in severe depression, people just are not able to kind of tune outside of themselves and have trouble with memory, relating to people, uh, making decisions that becomes a major, major, major difficulty. Another symptom oftentimes we see are persistent physical symptoms that don't respond to usual treatments. This can be headaches, it can be gastrointestinal pain, also chronic pain, which can become worse with depression. So all of these are symptoms of depression that I think are important to talk about and be aware of when they persist because they begin to take away the quality of life of the patient. So what can we do about this? And what are the goals in treating depression? Well, clearly, we want to help the patient feel better. We want the patient to be able to interact with their caregivers, with their family, and very importantly, with their physicians and doctors. As the patient feels better, they're much better able to be a participant in their care. And this is an extremely important aspect of treating depression that's beginning to interfere with those things. Um, so being engaged with people, being able to be active, something we definitely want to see improve. The goals that I see for myself and for therapists treating depressed people, help the patient kind of um, adjust to a new normal. They have cancer. They have a serious uh, medical problem, but it's something that if they come to grips with, they can begin to understand and begin to take control of and deal with in a positive way. Um, Going through other things that I think as a psychiatrist, as a therapist, we want the patient to be able to really deal with the sense of loss. I think cancer and all serious illnesses really involve loss, loss of control, um, loss of body image, loss of sometimes friends and relationships, loss of independence, all of these, loss of job. There are a lot of losses that go along with a serious medical illness. And I think helping the patient understand and deal with these is really very essential in helping the patient. Um, what are some of the treatment options that we have in treating major depression? Well, I'm a strong believer in psychotherapy. Um, Therapy is something that invariably is helpful. Oftentimes, therapy alone can effectively treat depression and help the individual in meaningful ways to start to feel better. And therapy can be performed by a number of different kinds of therapists, certainly by psychologists, by marriage and family therapists, by clinical social workers, and I think many times it can be extremely important to help the patient kind of begin to deal with their illness and have somebody who is not just a listener, but an ally in the process of dealing with the cancer diagnosis. Um, Other aspects of treating depression are, I think, embodied by the cancer support community. Meditation, mindfulness, visualization, yoga, Tai Chi, all of these can be extremely helpful. I think also the support groups that are available through the cancer support community are very helpful and valuable. Um, I'm a believer in mindfulness. I try to practice it myself, and it can be extremely helpful for patients that are dealing with conditions that don't have clear answers, a lot of uncertainty, can help the patient really begin to kind of feel a sense of peace, which can be therapeutic in the long run. The major thing that psychiatrists can do that other therapists can't do is to prescribe medication. And so we're going to spend a little bit of time talking about the various medications that I use, that I recommend, that can be helpful. Oftentimes, patients are on medications, and if the panel members have questions, you can ask me now, or we can wait till the end of the talk. But I'm going to talk about the medications that I have found useful and I think are most important to be aware of in treating clinical depression. 1988 was a banner year. It was the year that Prozac came into being. This is the first major antidepressant that was not just effective, but didn't cause the side effects that the older ones like Elavil and Tofranil did. The older antidepressants caused a myriad of side effects: um, dry mouth, dizziness, uh, constipation, um, cardiac issues, dangers and overdose. Patients had to feel worse in order to feel better because the side effects generally faded, but they were never really satisfactory. In 1988, Prozac came into being, and it really revolutionized the treatment for depression. Serotonin is a brain chemical, and Prozac is very effective in boosting brain serotonin. In illnesses like depression, serotonin is depleted. There's not enough serotonin in our brain. So we're not able to have the same kind of mental state that we do ideally, where we are able to kind of cope with adversity, roll with the punches. Serotonin not only is effective in treating and helping with depression, but also anxiety. So Prozac is what's called a selective serotonin reuptake inhibitor. A lot of words, but basically what it does, it boosts the serotonin in the brain. It takes a while to do so, and that's unfortunate because there's some initial minor side effects that patients experience, most commonly nausea, and that's because we have serotonin receptors in our gut. Also, these drugs don't work overnight. Patients begin to start to feel better within 2 or 3 weeks. By 4 to 6 weeks, they're feeling much better if the drug is working. And fortunately, in 70, 75%, 70, 80%, we do see an improvement, often significant, in that period of time. So basically, boosting brain serotonin by chemicals like Prozac, Zoloft, Lexapro, Celexa, all are called serotonin reuptake inhibitors, all boost serotonin, and all are very effective in treating depression. Sometimes patients will respond preferentially to one or over another. Often one doesn't work, and another will. So trial and error, unfortunately, is sometimes necessary, but these are good drugs, generally well tolerated by most of my patients. Um, Another drug that is often used, and I often use it both alone and also to augment the serotonin drugs, is a drug called Wellbutrin or bupropion. Wellbutrin boosts two other chemicals, norepinephrine and dopamine, which are also involved in regulating mood very effectively. Patients on Wellbutrin often feel a little more energy too. So I sometimes will add Wellbutrin to a drug, or I'll use it alone, but I'll add it to a serotonin drug like Zoloft or Celexa, and basically get the best of both worlds. Again, the serotonin drugs help with anxiety. Wellbutrin is more activating and helps with energy. So sometimes using both can be helpful, and the combination of the two is something that I often do. There's also drugs that combine serotonin and norepinephrine effects, and those drugs include Effexor, Pristiq, and Cymbalta. These drugs are often a good alternative if a patient isn't fully responding to a serotonin drug. Um, Switching to Effexor or Pristiq or Cymbalta can often be very, very helpful. Cymbalta also has been touted as helping with pain, and I've had a number of chronic patients with pain who have responded to Cymbalta, not always, but it sometimes is useful. So you can kill two birds with one stone, treat depression and also help with chronic pain. Sometimes we also will augment, and we can talk about this a little later, the antidepressants with other drugs. I'll mention one or two of them now. Abilify is a drug for severe depression that doesn't respond normally to the antidepressants. I will sometimes add. Um, Other drugs are, and also have uses for increasing energy and fatigue, are drugs called Nuvigil and Provigil. They can also accentuate the effect of the antidepressant and often help the patient feel more energy. Tranquilizers. Um, the tranquilizers are in a class called benzodiazepines for the most part, and they include Xanax, Klonopin, Ativan. They're often useful initially. I try not to use them long term because of their addictive quality, but they can be very, very helpful initially with a patient with severe anxiety, insomnia, and I often can use them along with a serotonin drug, although I try to withdraw the benzodiazepine over time as the patient's doing better. So sometimes for the first month or so, I'll use a small dose of Ativan or Xanax, but then taper and ideally try to stop it. Although there are exceptions to every rule, and there are patients that clearly just do better with the anti-anxiety drugs, and we keep them on them and just monitor their condition. Sedatives. What do we do with people who have insomnia? How can we treat insomnia safely? Everybody knows about Ambien. There's another drug called Lunesta. Very effective for sleep, but also addictive and also cause some problems you may or may not have heard about sleepwalking, sleep eating with Ambien. I had a patient that once was on an airplane ride and had taken an Ambien, was wandering around um, in the airplane, fortunately not the cockpit, fortunately around knocking things over, uh, making a bit of a racket, causing problems for the staff. And this is one of the conditions that sometimes occurs using Ambien and why I avoid it. So what do I use? The drug I most commonly use is a drug called trazodone. Trazodone was an old antidepressant that was very, very sedating. Turned out it wasn't very effective as an antidepressant, and because it had to be given twice a day, everybody fell asleep. So it really kind of fell out of disuse until psychiatrists realized this is a safe drug that we can use for sleep, help the patient fall asleep, help the patient maintain sleep um, after some initial grogginess, which goes away. A very, very safe alternative to the other um, sedative drugs. Generally, because it's slow onset, it's taken an hour before bedtime. Most of my patients with insomnia, this is the drug I tend to use. Another drug is Remeron. I tend not to use it. It causes a bit of weight gain and has some other side effects that I don't use. It's an antidepressant that's really not terribly effective in my experience, but as an alternative can be used for insomnia. Um, my patients also come in and tell me about what they're using for sleep, and they include things like melatonin, Benadryl, magnesium, um, uh, medical marijuana. All of these, I think, can be effective. I don't necessarily recommend, but I absolutely feel that they can be useful, and certainly they're safe and worth considering if all else has failed. What do we do with patients? I think I've told you that between 70 and 80% of patients will respond to the medication regimen that I've talked about. But what do we do with the patients that don't respond? Well, fortunately, we have some alternatives. And the major one that you probably all have heard of and know about is ketamine. There are ketamine clinics, and some of them probably are not as regulated and not as medically sound facilities as I would recommend, but there are several therapists in the South Bay that do ketamine, use ketamine, both intravenously and also by nasal inhalation. And ketamine therapy involves being in a clinic or a clinical setting under doctor's supervision, receiving the ketamine, and then remaining for about an hour afterwards. Generally, it's twice a week for about 3 weeks, then maybe once a week for a week or so, and then maybe monthly to maintain the progress. Ketamine was really a game changer because over the course of my career, I've had a number of patients that just failed to respond to all my treatment endeavors. This is called treatment-resistant depression. In the past, we had electroshock therapy, which still is used, still can be effective. Ketamine, I think, is a better alternative and one where I've had some good success with several of my patients in the last couple of years. So that's the big alternative treatment that I would recommend. There's also something called transcranial magnetic stimulation. This is where a patient receives a magnetic impulse to one side of the brain every day for a 4 to 6 week period. They have to go in every day. It's a very short period. They're able to drive themselves, so that's a good thing. Who would be a candidate for this? Patients that absolutely could not tolerate the medications, sometimes patients who have failed on the medication. Pregnant women sometimes prefer to use this treatment. My overall impression is that it's fairly effective, but not all the time. So it's something that and it's generally covered by insurance if it can be documented that the patient has failed on other medications. So that's an important consideration. Ketamine is not always covered, so that's another consideration. Um, the other drug I will mention, because it's gotten a lot of publicity also, is psilocybin. It's not, at least in this state anyway, available. In Oregon, New Mexico, and Colorado, it is available under certain conditions. It's also very expensive, and patients who are seeking treatment with psilocybin are really ones who have really kind of gone through the whole gamut of everything, including sometimes ketamine, and they're desperate for something. Good clinical data that shows that it's effective almost immediately. It's a very, very dramatic improvement. It's been very useful in clinical studies in post-traumatic stress disorder in the military, especially in military personnel. And it's something that I think you're going to hear and see a lot more of over the coming years. Uh, Recently, the federal government has relaxed some of the restrictions in studying drugs like marijuana, psilocybin, and I think that there are going to be more data and more information about how effective and when these drugs can be used. So, what are the benefits of treating depression? Well, of course, they have the patient feel better, have him become involved with his family, involved with the treatment team, have him regain control of his life. I think these are things that really are essential in helping the patient kind of return to a more normal life. Again, so much of treating cancer involves the physical aspects, but the emotional aspects are absolutely as important, if not more important, because if the patient isn't able to participate in the treatment process, participate with family and caregivers and friends, it's really I think a very, very major issue that needs to be addressed. Um, so why do we treat depression? For those reasons. Also, there is evidence, and I believe it, that cancer can actually slow the progress of cancer. I think that depression has a very profound impact on both the endocrine and the immune system. And in treating depression, we can often kind of ease that load on those systems. And so for that reason alone, although there's no hard data, for that reason alone, I think it's very important to um, uh, actively treat depression and make sure it's not an issue. I think I mentioned that 20 to 25% of cancer patients will have a serious depression. Unfortunately, not all of them receive the kind of treatment that they really need and deserve uh, to effectively treat depression, and that's definitely something that I would highly recommend considering. So, I've talked a bit about my thoughts about treating depression as a psychiatrist. My wife's a clinical psychologist. I work with other therapists. I've been on the Cancer Support Advisory Board for over 30 years. I'm a strong believer in the interaction between mind and body. And as a psychiatrist, I can bring my knowledge of medication into the other things that other therapists are doing that we've talked about. So I think in summing things up, I think treating depression helps give patients back their lives, helps them have a quality of life, helps them have meaning, helps them be able to cope, and and basically not just deal with their cancer diagnosis, but really get on with life and really be able to enjoy the quality of life that depression robs them of. So I think with that, I will take any questions. I know we covered a fair amount, and usually there are questions about medications that I would try to answer. Uh, Try to kind of go through the ones that I use, and there's a lot of interactions, a lot of intricacies in terms of using medications that sometimes patients have questions about. So with that, I will stop, Rebecca, and turn it over to any questions.
Wonderful. Thank you so much, Dr. Palmer, for
Sure.
reviewing all that information. So, if anyone does have any questions, feel free to type it into the chat and I can read it out loud. You can also direct message me, and only I will see the question. I can read it. After that, we will also open it up to those who want to maybe orally ask their questions. But please note that this workshop is being recorded. So if you do not want your voice to be recorded, please type it into the chat. And at the very end, I will stop the recording for any such questions that people want to ask. Okay, Dr. Palmer, can depression diagnosis quote unquote backfire when a patient wants to exercise his rights to end of life option act?
That's a very, that's a very heavy question.
Mm,
Um, I think that treating depression is something that is obviously a choice. Patients don't have to choose to follow along with any regimen that the doctors prescribe. They can stop chemotherapy. They could stop taking antidepressant medication. So it's a matter of, I believe, the patient understanding that if they're severely depressed, that there are treatment options that can very effectively treat the depression. End of life issues are maybe a separate kind of issue. If the patient really feels that there's no hope, um, then end of life issues, I think, take on maybe a kind of a different tone. In the state of Oregon, um, I think end of life is something that patients can choose. Um, California, I mean, I think we've become more lenient over the years, um, but it's not quote legal in this state. So I guess my question is, the patient has choices, um, but as a psychiatrist and as someone who has effectively treated depressions that seem not to respond to anything, if depression is really the reason that the patient is choosing end of life, I would really encourage that person to really look at all the options available that might effectively treat their depression.
Thank
Does
you.
that answer the question?
I think they were maybe referring to the End of Op Life Option Act using MAID as their choice. But we did have a recording for with Karen Morin, who is a
Hmm.
RN that works specifically with End of Life Options Act and MAID that they can also watch for more information.
Okay,
All
that's
right,
what I would
thank you.
recommend. It's something I'm not as familiar with, have not really dealt with. Certainly, I'm aware that patients do have options, and those are options that, again, I think are really left up to the individual to a great extent. Um,
Thank you.
sure.
Is there any real progress in psychiatry toward objective diagnostic tests?
Very good. That's the holy grail. That's what we look
Ah,
for. We would love to have a blood test or some kind of test that would tell us which antidepressant is most effective. What's the best way to treat this patient? We're not there yet. There have been
mm,
hints of that, but there's no hard evidence to this point that we have where we can say this is the right drug, this is the way to go. If you add this drug, you're going to get a better response. It's really kind of trial and error, and the experience of the psychiatrist or the doctor who has experience with the medications. So, I mean, a lot of it, unfortunately, the good news is that most people do respond to the first antidepressant that I prescribe. Most patients will respond positively within about 3 or 4 weeks to a serotonin reuptake inhibitor, which I think is the class of drugs that I would recommend and choose. Um, Not always, though. And then we get into the what do we do? Do we switch to another drug? Do we add something to augment the antidepressant? That's where I think the skill and the experience of the psychiatrist comes into play. We do not have a test at this point, that points us in the direction of a certain drug that might be helpful.
thank you. Um, this might be more for a nutritionist, but do you know if there's serotonin available in foods or, any other things besides medication? Um,
There probably is, but not enough to really help with depression.
mm,
Um, Basically, a healthy diet is very important. I recommend that to my patients. Um, um, Serotonin, unfortunately, um, doesn't cross the blood-brain barrier. So if there were foods high in serotonin, which I don't know of any actually, it wouldn't get to the brain where it really needs to be active. So the brain manufactures its own chemicals. What we can do is enhance that by boosting the amount. And again, to point out, in depression, serotonin is depleted. It's drained, and that's what often causes the depression and anxiety. In most cases, in milder depressions, it's replenished as people kind of adjust and adapt. But with severe depressions, that doesn't happen, and there's a more permanent kind of depletion of serotonin and norepinephrine and dopamine, and that's where these chemicals that we use to treat depression are effective because they can boost the serotonin in the brain.
thank you. Is there a relationship between medication for depression and dementia?
That's a good question. I mean, I think there's been concern about benzodiazepines, Xanax, Valium, Ativan, Klonopin long term. the jury's out, but there's concerns that these drugs could potentially uh, precipitate or um, worsen a dementia if it was developing. One of the reasons I try not to use these drugs in older people, there are again exceptions, but and there's not clear evidence of it. In terms of the antidepressants, there's absolutely no evidence that these drugs would anyway predispose to dementia. But the benzodiazepines, including the Ambien too, I would have more concern about, particularly using long term.
Thank you. Can you advise why with some antidepressants there are short-term memory issues, a forgetfulness that is more so than normal?
It's a very good question. This is mostly true with the serotonin drugs, and doesn't occur with everybody, but some people seem to be more prone to it. It's short-term memory. It does come. Memory is going to come back many times in adjusting to the antidepressant and to the serotonin drug. There is some difficulty with memory. It doesn't occur that often in my patients, but it does. It can occur. I reassure my patients that they're it's like more than likely going to get better the longer you're on the medication. It doesn't mean you're having dementia. It's not going to cause you to have any kind of long-term memory issues. It's something we can work around. If you need to, write things down. I don't worry about this as a symptom because it generally is something that resolves on its own, and it's not a serious issue.
Wonderful. What is your response to a patient living with anxiety that the cancer will return after remission was achieved?
Repeat the question again.
What is your response to a patient living with anxiety that the
Mhm.
cancer will return, even though remission was achieved?
Well, I would hope that groups like the cancer support community, uh, I'm again a believer in mindfulness, the kinds of deep relaxation things can be helpful. I mean, this is a kind of anxiety that's sort of an existential anxiety. It's a what if anxiety. Psychiatrists deal with this all the time with patients that are worried about something happening. Um, Medications can help, but maybe more importantly, talking to a therapist, doing relaxation, doing mindfulness, doing meditation, can be more helpful. Um, Clearly, I think anybody who has cancer has that concern, that what if it comes back? Um, in therapy, I would try to help that patient not focus on that, not be, because it takes away from them living in the present. It really kind of robs them of being able to experience life now. So hopefully, this is something that uh, could be dealt with. I think the cancer support community offers, again, a number of activities that could be very helpful in helping the individual. And in addition, um, talking to a therapist could also be helpful.
Thank you. Mm, what medication will be best? Sarition? Sarition.
Serotonin?
Maybe.
What,
Okay.
me-
Maybe that's what it means. Okay. What medication would be best for serotonin, I believe. Yes, yes.
what medication would be best for serotonin depletion, a lack of serotonin? I'm not
I
sure I
believe
understood the question.
so. Yes.
Well, the class of drugs, the serotonin reuptake inhibitors, which include Prozac, Zoloft, Lexapro, Celexa, those are the four main ones I use, are all pretty equally effective. Some people respond better to one than another. Prozac is more potent. Prozac I often use with my patients with obsessive compulsive disorder because it's really more powerful. And in high doses, it can absolutely cut back some of the obsessive worrying and concerns. So in regard to the last question, um, being on a serotonin drug could help, but it's only part of the answer. It's not the whole answer. The other means of helping with anxiety, I think, are as or even more important. But all the serotonin drugs work by the same mechanism. Some patients tolerate one medication and not another, so sometimes switching from one to another within the same class is helpful. Prozac is probably the most powerful, most strong. The one that patients seem to tolerate well. Celexa and Zoloft and Lexapro are all equal. And there's a great deal of variation. Some patients you can put on a therapeutic dose of a serotonin drug and they tolerate it immediately. They're feeling better within 2 or 3 weeks. That doesn't happen all the time, but that's great. Some patients take a little longer. They may have queasiness. They take a little time to adjust the medication. We have to increase the dose. Those are the patients that um, probably are going to respond, but you have to be patient. They have to be patient and understand that there's some side effects that are going to go away, the nausea, after a week or so, and that they're going to feel better eventually. But you have to kind of be a salesman and convince them that are not serious and that they're going to feel better. So I think, and that's the question as I understand it. The drugs I've mentioned all boost serotonin. Prozac is the most potent. Uh, the others less so. Again, we want to have the patient tolerate the medication. Oftentimes, patients who have a lot of nausea or have difficulty, I recommend having them take it with the yogurt in the morning. It seems to absorb it, and patients have less side effects overall. So that's a little trick I learned a long time ago. Patients actually told me about that, and I often recommend that with a number of my patients.
Wonderful. If there are any other questions, feel free to put it into the chat. Um, I think there, or you can also mute yourself if you would like to ask your question, but please mind that this workshop is being recorded. Wanted to make sure.
I guess the important point
Um,
I want to emphasize again is that people do not have to live with depression. And with cancer, there's a likelihood, a good likelihood that depression can become a factor that really impedes the patient's ability to live a normal life, and that with the right treatment, we can effectively treat just about all depressions.
Thank you, Dr. Palmer. That's very reassuring. All right. I just did want to thank you again for your time and for being here with us today to share
My
your
my pleasure.
expertise.